Assalamu alaikum. Welcome, students. Today I have a continuation of my previous topic only, that is shoulder dislocation. So I'll be covering shoulder dislocation in four topics. One is anterior shoulder dislocation. The second is recurrent shoulder dislocation. Third one, posterior shoulder dislocation and inferior shoulder dislocation. Okay, so we have done with anterior shoulder dislocation in last class. So I will be uh, studying today the recurrent shoulder dislocation. So we'll start with the history today, how the recurrent shoulder dislocation present to us. So here is a 50-year-old female patient. She had history of dislocation 3 times in last 1 year. So she had 3 times dislocation happening in last 1 year, and the first episode was following fall. So initial injury was a significant trauma. After that, the shoulder is dislocating without any significant injury or insult. So there, after the 2 episodes, when she was moving shoulder overhead and while traveling in the bus holding the roof belt. So this is how the presentation of the mechanism of shoulder dislocation. So here, if you see this old female patient, she is holding the hanging of the bus, and suddenly, if there is any jerk, she may have a land up in shoulder dislocation. So how will you describe shoulder dislocation, recurrent shoulder dislocation? It's a painful dislocation after minimal stress. So there is no significant trauma, just the dislocation is happening after the minimum stress at the shoulder joint. But there is initial episode of acute traumatic dislocation. So it is consequence of the acute traumatic dislocation first time. So what are the risk factors for shoulder dislocation? These are very important. So younger age group at the time of first dislocation. So if the child is the patient is very young at the time of first dislocation, there is high risk of him developing recurrent shoulder dislocation. Second is a patient who participate in high contact sports like football and all, there is high tendencies to have injury again. Then with Hill-Sachs lesion over the humerus or Bankart lesion along the glenoid. So this develops after acute dislocation. So if patient have acute dislocation, then fine, they have this injury. And if they have this injury, they have a high tendency to have recurrent shoulder dislocation. Or if patient has ipsilateral rotator cuff or deltoid insufficiency, it may be secondary to the primary dislocation and underlying the clinical condition with ligament laxicity. So there are few patients who have a lot of ligament laxicity. So due to that laxicity, the range of movement increases and suddenly it gives way. So here I just want to revise regarding the stabilization of the shoulder. So as I told in the last class, we have static stabilizers and dynamic stabilizers for the shoulder. Static means it's a ligament, so they won't change this dimension, or they won't change their length when they are contracting or relaxing. So what are these? There are two ligaments which are starting from the coracoid process. We have acromial ligament and coracohumeral ligament. Okay, then we have a condensation of a capsule, that is superior glenohumeral ligament, intermediate glenohumeral ligament, inferior glenohumeral ligament. And the labrum itself also increases the depth of the shoulder joint by 50% and give stability. So just to revise, we have static stabilizer in the two from coracoid process, coracohumeral and coracoclavicular ligament, and superior, middle, and inferior glenohumeral ligament and labrum. Then this is one important slide you need to just get it picturized with. So dynamic stabilizer, we have two dynamic stabilizer. One is rotator cuff. So what is rotator cuff, and second is long head of biceps. So when these muscles contract, they push the shoulder or towards the head of the humerus towards the glenoid. So they prevent shoulder getting dislocated. So this is your long head of the biceps coming from upper surface of the glenoid. So this when contract, it push the shoulder inside and it won't allow to shoulder go out. The same way we have rotator cuff. Here, as I told you before, we have rotator cuff anteriorly subscapularis, superiorly supraspinatus, posteriorly infraspinatus, and teres minor. When they contract, they push the shoulder joint inside the glenoid. So they prevent dislocation of the shoulder. So any injury to either biceps long head or any injury to rotator cuff decreases this dynamic stabilization and results in recurrent shoulder dislocation. And two important lesions you need to remember when you are reading shoulder dislocation. One is, as I told, it's a Bankart lesion. Bankart's lesion. What is Bankart lesion? I told in previous class also, if you see this is the glenoid labrum, what is happening is when shoulder or head of the humerus move out, it damages the anterior inferior aspect of the glenoid. So it's a anterior inferior location, glenoid labrum. So what happens is this is a normal shoulder joint and the glenoid is in line with glenoid labrum is in line with glenoid. So here if you see it got damaged here and it got separated from the bone. So the depth decreases. So every time the shoulder moves, it may go out. So this Bankart lesion causes increased tendency of shoulder going into dislocation again and again. So Bankart lesion involve anterior inferior aspect of the glenoid labrum. The second lesion is your Hill-Sachs lesion. Hill-Sachs lesion, always you remember Hill, H for humeral head of the humerus. So it happens in head of the humerus. So what is happening is, if you see, this is a posterior, this is the spinous processor, this is the posterior surface of the scapula. So here, if you see, the shoulder has moved outside anteriorly. So the posterior surface of the shoulder, posterior lateral surface of the shoulder is hitching towards the anterior surface of the glenoid. So this causes dent or depression in the posterior lateral humeral head. So when you reduce it, this is how it appears in the posterior lateral aspect of the humeral head. This lesion is called Hill-Sachs lesion. Hill-Sachs lesion is very important because it sometimes engage in external rotation when you are doing external rotation and causes repeated dislocation. Here in this slide, if you in the last diagram, if you see, this is a normal anatomy of the shoulder joint. This is your glenoid, this is your humerus. Okay, and this is your capsule. So what happens is when you are external rotating, this round part of the shoulder is in contact with the glenoid cavity. But if you see, this is the patient who has here Hill-Sachs lesion. So there is dent. When you are external rotating, this dent engage with the glenoid. So when you try an external rotation, it engage with the glenoid. And when you are trying to get it back, or when you are trying to internal rotate, it get lifted out. So as a fulcrum, it get lifted out and result in shoulder dislocation. This is the mechanism by which a Hill-Sachs lesion causes shoulder dislocation. So labrum lesion is Bankart lesion, head lesion is Hill-Sachs lesion. So we'll move on to the next slide. So there is one important test called as apprehension test in shoulder dislocation. What is this apprehension test? If patient who is having tendency to have recurrent shoulder dislocation, when you abduct and external rotate the limb, he won't allow you to do it because he has fear that the shoulder may dislocate again. This test is very important for eliciting the patient tendency to have recurrent shoulder dislocations. It's called as apprehension test. Apprehension offered by the patient when you are doing abduction and external rotation of the shoulder joint. So this is how you diagnose the patient who is having shoulder dislocation. So here, what are the investigations you do? Investigations is X-ray. Sometimes we do to look for any bony injury, obvious bony injury. But we do CT scan, most often CT scan to know the Hill-Sachs lesion. And MRI, we do MRI to look for any labral tears and also for rotator cuff pathology. As I told, rotator cuff are dynamic stabilizers of the shoulder joints. They have strong, holding capacity or stabilizing capacity for the shoulder joint. So any damage to the rotator cuff also causes increasing chances of having recurrent shoulder dislocation. That's the reason we need to look for the rotator cuff activity before you plan for any intervention. So this is a broad classification. How will you treat a shoulder dislocation? A recurrent shoulder dislocation. If patient is having recurrent shoulder dislocation, we need to find out what exactly the pathology. If there is a Bankart lesion, or if there is any Hill-Sachs lesion, or there is laxity of capsule with dynamic stabilizer defect. So if patient is just having a Bankart lesion, then what you will do? Bankart's repair. We need to, whatever lesion is there, we need to repair that Bankart lesion. So how will you repair? We can either go for open repair or arthroscopic repair. Here, if you see, there is a lesion here, there is a defect here. Okay, we have reduced this defect and put the suture anchor. So this is the either by open or arthroscopic repair. This is your Bankhart's repair. So Bankhart's lesion is a cartilaginous lesion along the anterior inferior aspect of the capsule, and repair is the arthroscopic or open repair. Then comes your very important Hill-Sachs lesion. So Hill-Sachs lesion, you need to do CT scan to know how much amount of head of the humerus is involved. If it is less than 30% involvement of the circumference, if this is the circumference of the head, it just involves this much, less than 30%, the treatment is different. If it is more than 30% involvement, like more than 50% or anything, the different treatment is different. So what if you also less than 30%? Less than 30% mean you can salvage the head. So what you can do is, this is a procedure where you just transfer the lesser tuberosity. If you see, this is subscapularis muscle inserting into the lesser tuberosity. What we can do is, we can detach it like this, take it out and fix it like this. So this is transfer of greater tuberosity. So we are filling the defect by using greater tuberosity along with this muscle attachment as a graft. So that will no doubt decrease some movement, but it fill up the defect and decreases the chances of patient having recurrent dislocation. But if it is more than 30% of involvement, the only treatment available is we need to go for replacement of the shoulder joint. That is called a shoulder arthroplasty. Then what if patient is having laxity of the capsule? How will you treat laxity? We have two procedures. One is Bristow's, or other a similar procedure called Letarget procedure. Other is Putty-Platt procedure. So what is Bristow's procedure? If you see, I just got this figure. This is your coracoid process. What muscle attached to the coracoid? It's a crociobrachialis, and we have short head of biceps. So what we'll do is, we detach this short head of biceps along with the tip of the coracoid and place it back here over the anterior aspect of the glenoid. So that will increases the surface area of glenoid and it decreases the dislocation. This is what we have done. We have cut it from the tip of the coracoid and placed it anterior to the glenoid. So this will increases the surface area of the glenoid. So it then increase surface area, decreases the dislocation chances. This is the other picture of same thing. So it goes by name Bristow's procedure or Letarget procedure. Other is a Putty-Platt operation. What is Putty-Platt operation? Here what we are doing is, this is subscapularis muscle. Anterior dislocation, anterior laxity is there. So anterior muscle is subscapularis muscles. So what we are doing is, we are cutting the subscapularis muscles and double bracing it. So if you have these muscles like this, subscapularis, 1 minute. So you have a subscapularis muscles like this here. And this is your humeral head. This is your glenoid. What we are doing is, we are cutting it and we are double bracing it. So we are relatively shortening the muscles. So overlapping the muscles. So when you overlap the muscles, there is tension created and that pushes this one back. So this is called as double breasting. So double breasting or Putty-Platt operation is over the subscapularis muscles, where we double breast the subscapularis. So this is all about management of recurrent shoulder dislocation. So points to remember here in anterior dislocation is, in first class, as I told, we have dynamic stabilizers versus static stabilizers. Okay, then second thing is, the shoulder is most common joint to get dislocated in adult, followed by patella and followed by your elbow joint. But in children, it is elbow joint, which is more common. Then the third thing, what is, we have anterior dislocation more common than posterior dislocation, more common than inferior dislocation. Along anterior dislocation, we have subclavicle, where the shoulder comes below the clavicle. Then we have subcoracoid, where shoulder comes below coracoid process. We have subglenoid, where shoulder head of the humerus is below the glenoid. But the common one is subcoracoid, CO for common. So then X-ray and all we do for investigation. What is the acute reduction? We have Hippocrates method, where we use the person who is reducing, he'll keep his feet in under the axilla. The other methods are traction, counter traction method, then Cocker's method. The last is by using the gravity, that is Stimson's gravity method. Then among the Cocker's method, we have, I told the mnemonic T India. So we give traction in line, external rotation, then adduction, then internal rotation. Then if after adduction, we have two lesions here. One is Bankard's, it affects the glenoid. Then we have Hill-Sachs. It affects the head of the humerus, head for H, head of humerus. Then depending on this, patient have a recurrent shoulder dislocation. So we need to go for glenoid repair, or we can go for head of humerus Hill-Sachs lesion repair by using subscapularis muscle transfer, muscle block, scapularis muscle block, or we can go for arthroplasty. Then if there is a rotator cuff and all, what we can do is we can either do putty-plat operation. Putty-plat is double bristling of subscapularis, or we can go for letarget. Letarget is what we are just transferring the coracoid process to the anterior aspect of the shoulder joint. That's all for the anterior dislocation and recurrent dislocation. In next class, I will be dealing with posterior and inferior dislocation. Thank you.